Good evening, everyone. It's 7 p.m. UK time. Thanks, everybody, logging on for the first TUGSS Emergency General Surgery session of 2023. The first topic that we plan to cover is acute limb ischemia for the general surgeon. And this evening, our speaker is my colleague, Stuart Suttie. He is a vascular surgeon based at Ninewells Hospital in Dundee, which is up in the east coast of Scotland, kind of like north of Edinburgh, south of Aberdeen. It's where I trained. He trained me and did my vascular block. And he also happens to be the National Training Programme Director for vascular trainees across the whole of Scotland. So without further ado, I'll hand you over to Stuart.
Michael, thank you very much. Got some big shoes to fill now, being built up very well. So as Michael says, I'm Stuart Suttie, one of the vascular surgeons in Ninewells up in Dundee, a bread and butter vascular surgeon who deals with the day-to-day stuff. Just bear with me while I try and share everything now. Try and get the full screen for everybody. Oh.
Stuart, it went on and then immediately off there. So
is that working now?
It is for me. Yeah.
Can everyone? There we are. So, Michael, thank you again for the invite. And what we're being asked to talk on tonight is the acute limb ischemia for the general surgeon. Now, many of you know the old days, vascular surgery was a part of general surgery, and I am a general surgeon by trade. So I'm going to try and keep it very focused, rather than going into too much detail about the ins and outs and complex management, but try and focus it for the general surgeon, what you need to know. So hopefully by the end of this talk, be able to define acute limb ischemia, also known as ALI. You'll be able to distinguish acute from acute on chronic limb ischemia, which is very key to its management, describe the pathophysiology, hopefully get a good grasp of the generic principles of the management, and be able to describe some of the operative management. And I think the whole point of this talk is so you are aware of it as a general surgeon, you're able to identify it, think of it in terms of your differential diagnoses, and also able to construct the management plan and feed your findings to a vascular surgeon to help the management. So there are some really good guidelines for vascular surgery. It's found on the European Society of Vascular Surgery, and they cover a whole host of guidelines from mesenteric ischemia all the way through to aneurysms, and they've now got a really good one on the management of acute limb ischemia. And it's a really good read. Again, in all these guidelines, they have all the different classes of recommendation and the different levels of evidence. I think it's important that most surgeons understand the classes and the levels of evidence, because the guidelines will quote these. I think it's important to know exactly how, what the evidence is for these guidelines. It's not always as strong as we think. So to me, we teach our trainees acute limb ischemia as part of a triad of acute threat to the limb. And that includes acute limb ischemia, acute on chronic limb ischemia, which is what we're seeing more of now, and it's more complex, and also the sepsis, the diabetic foot sepsis. All of these pathologies can rapidly lead to a loss of limb. So what is acute limb ischemia? It is a sudden loss of blood supply to the limb. Now that can be occlusion of a native artery, you block off your own arteries, or there's a block bypass graft or stent graft. And what is key is to distinguish, I'll keep laboring this point, between acute and acute on chronic limb ischemia, because they have different urgencies, completely different management, and it all comes down to history and examination to help you distinguish between the two. So what causes the sudden loss of blood supply to a limb? It's embolism or thrombus, commonly from the heart. We can also have an atheroembolism, a bit of atherosclerotic plaque that can break off and occlude the smaller vessels. We might have an arterial dissection, a dissecting aorta, a dissecting femoral. It can also be post-trauma. Commonly, we see it in iatrogenic trauma. Again, it could be a dissection. Somebody stuck a needle in an artery, caused the 3 layers to dissipate, break down, and you got blocked artery. Orthopedic surgery, etc., etc. The upper GI surgeons might also see extrinsic compression from malignancies. Grafts can include, and there's also some very rare and uncommon causes which we don't really need to concern ourselves with. So what do we see when somebody presents with acute limb ischemia? We have the classic 6 Ps. There's pain. There's pallor. In other words, the limb goes white. There's no pulses, so it's pulseless. The limb becomes very cold, perishingly cold. The limb may then develop paresthesia, altered sensation, which, if it's untreated, can progress to full limb paralysis. And I'm going to talk a bit about these in more detail. What's also key in the features in the history is there's no prior history of intermittent claudication in that limb. That is key. In an ideal world, we'll find a cause for the embolism. We don't always find the cause, but it does help make the diagnosis. And again, in an ideal world, the embolus or the acute limb will affect one limb, meaning that the other limb should have a full complement of pulses. This all aids and points towards the diagnosis of acute versus acute and chronic. So the pain, it is sudden, it is severe, it is unrelenting, it is resistant to analgesia. Patients will be sucking back opiates to try and get relief. The pain will progress. They might start to get compartment tenderness. In other words, the muscles in the leg or the arm that are affected beyond the blockage can become tender. They may also start to develop a very tight, woody sensation. If you compare it to the other limb, the nice and soft and fleshy, the acute limb over time, these compartments start to become hard. It's like a woody feel. And this is a sign of compartment issues and indicates underlying muscle necrosis. And when it gets to this stage, we're starting to see irreversible damage to the limb. The limb will go white initially, but over time it's going to fill with stagnated blood, deoxygenated blood in the capillaries, and it can give the limb a mottled appearance. It's like a purple-blue appearance. It's confluent. Initially, if you were to gently push on this area with your thumb, it will blanch, it will go white. But over time, this mottling becomes fixed. And these are some of the key things to get across when you're referring to a vascular surgery. When it becomes fixed, usually it's the limb is in a non-salvageable state. In other words, if you do try and revascularize it, you're going to revascularize a non-functioning limb, but we'll also come on to in a wee bit later about the reperfusion. Okay, so when it's non-blanching, it usually indicates it's irreversible ischemia. Paresthesia paralysis, you start off with a sensory defect. It can later become a motor defect. It's usually an indicative sign of muscle and nerve ischemia. It's still salvageable if there's prompt revascularization. But once you progress to full limb paralysis, non-blanching mottling and calf tenderness, we're usually beyond salvage. So it is a sudden onset of excruciating pain. It happens in the peripheries and progresses proximally. It can be worse in muscular movement, particularly passive flexion of the foot. It's important to know the duration of the symptoms. A lot of books will quote, you've got 6 hours to fix a leg. It's not quite so clear cut. But if it's been going on for 1 to 2 days, then we know we're at the far end of the spectrum of the limb ischemia. I always think it's important to work through other things that might be related to it. Does the patient have a history of palpitations, recent chest pain, recent shortness of breath, recent cough? Are they known to have a dysrhythmia? Are they anticoagulated? If so, what are they anticoagulated with? Is it therapeutic? Is it subtherapeutic? If they're not anticoagulated, why not? And it's really important, again, I'll labor the point, to pay particular attention to history of atherosclerotic disease, i.e. lower limb claudication, because that will then dictate the type of management. This may be acute on chronic ischemia, and that is a completely different ballgame. So ultimately, what we're looking for a cause of the embolism, ideally a full complement of contralateral pulses if it's just affecting one limb. Be wary of saddle embolus in the aorta, it will affect both limbs. No prior history of claudication. And what's really good is an accurate description of the clinical findings. So you're able to get the information across to a senior or a vascular surgeon, and therefore it makes it very easy for the referral, and you grab the attention of that vascular surgeon. So we have a time frame. There is progression as time goes on, important to know the duration, the symptoms, but it's never as clear cut as the textbooks say. It really comes down to your clinical findings, okay? So for the first few hours, the foot or the limb may be white, very painful, a bit of a sensory motor defect in terms of paresthesia, the limb's still salvageable. As it progresses, you start to see mottling, it may still blanch, the limb may still be salvageable. But as you start to near 12 hours or longer, you're usually looking at a non-salvageable situation. However, I wouldn't base it on time alone. You really need to look at the clinical features. They will dictate to the surgeon whether the limb is still worth saving or not. So we've made the diagnosis of acute limb. What do we need to do? We need to decide, is the limb still salvageable? What management are we going to have? Empiric, generic management? Do we need imaging? What interventions can we offer to save the leg? And this is where we keep in context, revascularizing a non-viable limb can be catastrophic with a reperfusion syndrome. You release a lot of toxins, you have cardiovascular collapse. So if the limb is non-salvageable, we must state it as non-salvageable, and therefore you do not try to revascularize it. It can end in fairly rapid patient death. So we decide the limb is salvageable. How do we do this? Well, it's a function of time since onset of symptoms, the clinical findings, the extent of the thrombus load. Can we clear the thrombus? What is the patient's status? Are they 99, multiple malignancies, etc.? And is it an upper limb versus a lower limb? We have different timeframes depending on the limbs. Empirical management, bit of a busy slide, but it always starts with the ABCs. Resuscitate, investigate, check your biochemistry, check the renal function, check your full blood count, check the clotting, check the platelets. It's important to do an ECG to look for an underlying dysrhythmia, or has the patient had a silent myocardial infarction? Supplemental oxygen is key. If there is a dysrhythmia, let's get it rate controlled before we embark on surgery. That will end in catastrophe. And then we decide on imaging. Do we need to get imaging? Many years ago, if we had somebody that presented with this isolated limb, acute limb ischemia, a known cause, full complement of contralateral limb pulses, we would probably just embark and try and do something. But nowadays, it's never as clear cut. And it's now imperative to get imaging, which we'll come on to in a wee minute. Next question is, do we anticoagulate the patient there and then before we embark on theatre? The theory behind it is it stops propagation of thrombus. Sometimes it allows collaterals to open up and you can actually improve the perfusion to the limb. But you've also got to take into context what we're planning to do to the patient. A lot of embolectomies we can consider under local anaesthetic. Our unit, we've got a big drive on for regional anaesthesia. And if we fully anticoagulate someone, you've then lost the option for regional anaesthesia. And there's a reason why we use regional anaesthesia we'll come to later. So looking at the guidelines are very full, very detailed. And you can see here a lot of people will still try and use biochemical markers to give you an indication of the degree of ischemia, a bit like in mesenteric ischemia. The markers can be completely normal. In particular, creatinine kinase may be normal. It may be up. It may be 200,000. It doesn't always indicate whether the limb's salvageable or not, or what you're going to do. It's a nice adjunct to it, but you mustn't rely on it. Looking at the evidence for preoperative anticoagulation in the form of heparin, we've got a class 1C. The evidence isn't fully there. And you've got to take into account what you're planning to do. So a lot of units in Scotland, some will offer preoperative intravenous heparin. Our unit, we tend not to if we're planning theatre. We will get into theatre rapidly and anticoagulate once under anaesthesia. Imaging. I think in this day and age, imaging is now key. Particularly, we're not always just dealing with a straightforward acute limb ischemia. As you said here, if there's no prior history of claudication, we had a known cause for an embolic event, there were pulses all in the other limbs. Would we need to do imaging? Now, I would say, yes, we do. So what imaging would you do? Well, it depends the time of day, what is available, and local expertise. One of the quickest imaging to do, which gives you the majority of information you need, is a CT angiogram. It is rapid. It lets you see the arteries in detail, any calcification, any underlying stenoses, but it also lets you know the extent of the thrombus load, and it helps you plan the procedure. Downside is a lot of radiation requires contrast, but that is a necessary evil to save the leg. During the day, we in our unit have got access to a great ultrasound lab, a vascular lab, where we can get really accurate duplexes. Not everyone has that, and we certainly don't have it out of hours. You can use MR angiograms, but the MR in most hospitals is a really sought after investigation. To do the MR angiogram, it takes 45 minutes to an hour, requires time of flight and programming. The patient has to be able to lie still for that time on the flat, and they can sometimes really struggle to do that. We can also consider the old one of the digital subtraction angiogram, but it's invasive, it requires needling of the arteries, it requires an IR suite. It's not really done now as the first line investigation. I suppose the choice investigation would be CT angiogram. And this is backed up by the guidelines, but the guidelines have to take into consideration what units have available in their expertise. But imaging is recommended. So a very brief algorithm. Is the limb salvageable? Yes, no. If so, what are we going to do? We have tricks up our sleeves for multiple different issues. If it's not salvageable, we then have to consider palliative therapy or an amputation. So you have to be very upfront with the patients and their families from the outset. What anaesthetic? Local versus regional versus general. Down to local preference, what you're planning to do. But it should be in conjunction with anaesthetist. And again, the guidelines reflect this. Personal choice, unit choice. However, if you're doing local anaesthetic to do an embolectomy, you've also got to consider what you might need to do after the embolectomy. And can you get this done under local anaesthetic? So what can we do? We still do a lot of open interventions. And if this is for an embolic event, we'd consider a thromboembolectomy. Sometimes, rare, we cannot clear the clot. We then have to consider surgical bypass. Few and far between for a true acute limb ischemia. More common for the acute on chronics. We have combined treatments up our sleeve. We might do an open thrombectomy, find an underlying stenosis, and we can do stenting, balloon angioplasty, or thrombolysis. We now have some tricks up our sleeves where we can do an all endovascular, where we can aspirate the clot. And we're starting to do this in some of our acute mesenteric ischemias. Option depends on what your unit has expertise on, the patient's status, the site and the extent of the clot and what needs done, but also the degree of ischemia. What we mean by that is you might not consider a 6-hour thrombolysis period if there's profound ischemia and we need rapid clearance for limb salvage. So open is the thromboembolectomy. We still use the Fogarty embolectomy catheters. We can now do over-the-wire embolectomies. If we got concern that there might be underlying arterial disease, we might pass a wire down under image intensifier. And then we pass the catheter over this, clear the clot out, and then we do an angiogram. And if we do have underlying narrowings, we can then stent and treat as we need to. We still have the bypass option, and as always, we try and use the patient's vein, autologous vein, over pacetic if we can. Hybrid procedure, in other words, we're combining open with an endovascular. We might have partial success in clearing the clot. We might need to use thrombolysis or aspiration of the clot as an adjunct. But this really comes into its own in acute on chronic disease where there's underlying atherosclerotic disease. And we get that from the history, the examination, and partially from imaging as well, where we can combine clearing the clot with a treatment for the underlying arterial disease at the same time. Thrombolysis, it can be systemic, probably not what we do nowadays. We tend to use catheter-directed lysis. In other words, we can supply the lytic agent directly to where we need to get it. Gives us a higher dose in the local area, reduces the complications. We sometimes do it percutaneous, but more often not combined with an open procedure. And there's multiple different lytic agents. We tend to use recombinant tissue plasminogen activator, RTPA, in our unit, but you can use urokinase, streptokinase, whatever your unit has got expertise in. And you will see a marked variation in practice in the units as well. There are contraindications to lysis. So if you're going to embark on it, you really need to make sure it is safe. There's no point saving a limb to not have a functioning patient at the end of it, okay? I'm not going to go into all the contraindications, but the absolute contraindications are active bleeding, neurosurgery recently, or a recent stroke, because you can get a hemorrhagic conversion of that, or any major recent trauma. But there's a lot of gray areas, and it comes down to a balance of risks, unit expertise. So again, it comes down the risk of bleeding versus the risk of surgery. And it's all there in the guidelines. Recommendation 2B, level C. The other question, more so for the vascular surgeons, is at the end of the clot clearance, should we be doing an angiogram to see if we've done the best we can? Well, most of us would tend to do it. It's recommended 1C. I think a lot of places would do it on a selective patient cohort. If I had a 93-year-old patient who was unfit, did an embolectomy, the foot rapidly pinked up, I think I'd leave it at that. If I had a 50-year-old, foot was gradual to pink up, I would do an angiogram. There might be further thrombectomies we can do, or might require further adjuncts. So our unit, we tend to do it on a selective basis, particularly out of hours. Then it comes down, once you've cleared the clot, the big thing on all of our minds is, should we perform fasciotomies? Why do we consider fasciotomies? Well, it's a development of compartment syndrome. You get ischemic reperfusion, the muscles will swell, the muscles are confined in their compartment, which will not expand, and you get marked compression, the capillaries, arterioles, veins, and you can get ongoing ischemia. It's also balance versus upper limb versus lower limb. It's very rare for us to require fasciotomies of the upper limb following an embolectomy, unless there is profound ischemia. The arm is able to tolerate ischemia for longer periods of time. And in fact, some emboluses into the arms may not require surgical intervention at all due to the collaterals. The lower limb is a lot less forgiving. And I think if we're going to do an acute limb embolectomy, the vast majority of vascular surgeons would do a fasciotomy at the time. Now, there's a reason for that. Clinical diagnosis is all about prevention. Fasciotomies are preventative. if you end up requiring a delayed fasciotomy, 50% of patients will require an amputation within 30 days, compared with people that have fasciotomies, 6%. Complications of fasciotomies are rare if done appropriately. The wounds can heal up, you can get skin grafts, and most patients don't mind them. They would rather have a limb that looks just slightly abnormal rather than a well-perfused, non-functioning limb, which is what you'll get if you do not do timely fasciotomies. So if in doubt, do the fasciotomies. Lower limb fasciotomies, vascular surgeons, most units will do it themselves. Upper limb, a lot of units will get plastic surgeons involved because it's not just the arm. You can end up having to do fasciotomies in all the different hand compartments as well. And there's an art to that. What is the outcome from acute limb? Mortality is high, and that is not down to vascular surgery doing embolectomies. It's down to the patient status and the underlying reason for the acute limb. You have a 30-day mortality of up to 30%. It is high. You might do a beautiful operation, salvage the limb, but due to the cardiac status, which caused the embolus in the first place, the patient can rapidly deteriorate. Amputation outcomes, 15% of patients overall will have an amputation within 90 days. But 5-year freedom from amputation is very good if we catch it and treat it in an appropriately timely manner. These outcomes, particularly the limb outcomes, is related to the etiology of the occlusion. Okay. Again, the guidelines have got a lovely algorithm which is good to follow. It's a bit more detailed than my simple one at the start, but it covers most bases and it's nice to familiarize yourself with. Looking through the guidelines, guidelines are very good. We get a lot of trainees that will live their whole life via guidelines, but they are just guidelines. These guidelines, I think they're really good, very detailed. They pulled all the evidence they can find to make these guidelines. There's 61 recommendations. But if you look at it, a lot of them are C in levels of evidence. In other words, not all that good. And taking a quote from Seamus O'Mahony, who's a retired consultant gastroenterologist, from his book, Can Medicine Be Cured? The Corruption of a Profession. In the hierarchy of evidence espoused by evidence-based medicine, consensus statements are near the bottom, slightly above a bloke told me down the pub. And if you look at level of evidence C, it is a consensus of opinion, okay? But it is a group of experts and it's best practice. So it's good to listen to, but it doesn't always hold true. So hopefully it's a quick overview of acute limb ischemia. For the general surgeons, it's about recognizing the pathology, working out if it's acute versus acute and chronic, being able to examine the patient and be able to feed your examination findings over to the appropriate team for further management. And hopefully this has helped with that. And over to Michael and everyone else for some questions.
That's great, Stuart. If you can unshare your screen. Grand. So there's an opportunity here to ask specific questions directly to Stuart. I've asked people to unmute if they wish to do so. I gave Stuart the brief of covering the vast topic of acute limb ischemia and focusing it on the general surgeon. So I think I'll ask the question. I work in a unit that doesn't have a vascular surgeon on site other than for some elective stuff. So some days there is no vascular surgeon on site, and certainly for anything as an emergency, it's quite often either myself or my trainee that is asked to see the patient. So for you, if you're in the tertiary vascular service, what's the key bits of information that you're looking for if I'm phoning you to say, I think I've got an acute limb here?
I think that's very valid, Michael. I think we're seeing centralization of vascular services. The old days used to get a lot of kickback from vascular teams, but now I think we need to recognize we are there to support. And I think you'd be a very brave vascular surgeon not to accept the referral if somebody mentions acute limb ischemia. So the key things I've been looking for is, what is the status of the limb? Is it salvageable? Is it non-salvageable? What are your findings? Is it paresthesia versus paralysis, tender muscles versus no tender muscles? Has it got mottling that blanches versus non-mottling, non-blanching? Those are key. But irrespective, it probably should still head the way of a vascular surgeon for that final assessment, because we don't always get it right, particularly at 2, 3 in the morning. I think the main thing is to recognize there's a problem, do the history examination, and make the appropriate referral. We have a big network. We cover Tayside and Fife and a bit extra. And our Fife A&E colleagues and general surgeons, they're really good. They're primed. They know if they get someone in, they will organize a CT angiogram without passing go, because they can get it done rapidly, in and out of hours, doesn't really cause any delays. And when they make the referral to us, we can then look at the scan and say, yes, it looks like thrombus. Let's get them up. The other thing we want to know is it appropriate for the patient to be referred in terms of, are they a nursing home resident? The family want nothing to be done with them, severe dementia and a non-salvageable limb. And if the team are confident making that decision, but I would still run it by a vascular team as well for your own backup, then I suppose palliative therapy could be offered in the base unit. But if in doubt, pick up the phone and make a referral. Most vascular units now are primed. We've taken centralization to the key, but it means we have to be very supportive of our colleagues in outlying units. And I think we as a team need to accept that. And vice versa, they may come up to the unit, nothing we can do, or there's not an acute limb, needs nothing done. We can easily liaise with the home team and transfer them back for something else. No harm. It's all about the patient and looking for good outcomes.
Sorry, great. Thanks very much for that, Stuart. Nobody's posted any questions on the chat that I can see, and I'll chat for a few more seconds, but I'll look towards wrapping it up in the next minute or so. All that it takes me is just to thank you for giving up your evening. I know you've got kids to look after because your wife's abandoned you as she flies off to on a wee jolly down south. So you got to go off for your daddy duties shortly. And I just wonder whether you would be consider in a few months' time coming back and talking to us about mesenteric ischemia.
Michael, more than happy. I'm also, if people have questions at a later date and want to get in contact, more than welcome to. Mesenteric ischemia, I think that's another key topic. There's still a lot of debate, vascular versus general surgery, and marked variation in practice. Yeah. So yeah, more than happy.
I think centralization's had a massive impact on that.
It has, and we don't always get it right.
Yeah. Right, so without further ado, it's taken us 33 minutes to get through that. I think the rest of the evening in the UK, or whatever time it is, wherever you are, thanks everybody for logging on. This session's been recorded, so if you want to go back and watch it, give me a couple of days and I'll have it posted up on the TUGSS YouTube channel, hopefully before the weekend. Thanks, everyone.
Thank you very much, and thank you for listening, people. Appreciate it.